IC of third day, that is OCT, interpreting the image. So I'll be I request all judges or also all speakers to come and sit with me. Dr. Jyoti Prakash Vyas, Dr. Sailesh Kumar, Dr. Dilesh Chandrasekharan, and please Dr. Kiran. I request first speaker Dr. Jyoti Prakash Vyas. He will be presenting on deciphering OCT in AMD and PCV.
Good morning, all. Thank you, Dr. Anubhav, for the invite to the IC. I'll be talking about OCT in AMD and PCV. So this is the normal looking macula on an OCT. You can see the well-defined layers, and we'll be trying to explain what to look for and interpret in a case of AMD as well as PCV. This is an animation just to show. If you can see, I don't know, it's an animation showing the macula and the outer retinal layers and the underlying choroidal vasculature. So the retina normally receives nutrition by diffusion from the choroidal layers, and the waste products from the RPE are pumped up into the choroidal vasculature, which drains off into the venous system. In due course of time, as the retina ages, the RPE cells get a bit older. They tend to, their functionality reduces, and they tend to accumulate a lot of lipofuscin into the space, and which leads to reduced oxygenation of the RPE cells and accumulation of drusenoid material in the course of events. This is the histopathological structure of the RPE cell and the Brooks membrane, where the early basal lamellar deposits are seen, and the basal linear deposits are seen exterior to the basement membrane and between the Brooks membrane, which is said to be the precursor of the drusenoid material. Development of a subfoveal CMVM, in contrast to just the deposition of lipofuscin, begins as a growth due to the relative hypoxia of that particular layer, leads to a development of new vascular fronts below the Brooks membrane. In due course of time, there's a breach which develops into the Brooks membrane. The vascular structure comes to lie in the sub RPE space. Then exudation begins. Breaches occur, microrips occur in the RPE, the fluid travels across into the sub-RPE, subretinal space, and subsequently neovascularization follows. So now with this backdrop, now if we start looking at cases of AMD, the first thing which we look at is the drusen, as I had put forward. Now these are seen as little bumps in the outer retinal layers, and they can be seen either as a singular deposit, multiple lesions, and as the disease progresses, they can be seen as a confluent lesion when clinically it is seen as a soft drusen. When they clump together, they are labeled as drusenoid PED, and these are said to be precursors of wet AMD. When you see a drusenoid PED, the chances of progression are slightly higher than isolated drusens. Now, PEDs, that is pigment epithelial detachment, can be of various types. It can be serous, fibrovascular, or hemorrhagic, which can be seen in the photographs in the front. The serous has a hyporeflective space, empty space without any backscattering under the RPE. The fibrovascular element does show some element of backscattering just beneath the tip of the pigment epithelial detachment, which highlights the area where the fibrovascular element is there. And in the hemorrhagic, you can only see significant backshadowing because of the thick blood present there. This is a type 1 macular neovascularization, as it is nowadays called. Earlier it used to be called as choroidal neovascularization. Now it is labeled as macular neovascularization. Now in this, if you just look at the individual elements, this arrow shows the area of intraretinal fluid. This is the subretinal fluid. This happens to be the subretinal hyperreflective material. This is the area of backscattering from the fibrovascular PED, and this happens to be the the thinned out choroid, the compacted choroid, as opposed to a pachychoroid, which is seen in PCV and its variants. Now, this is one case in which we saw the fundus of a patient who has drusen in the left eye, in both the eyes, and the right eye also shows a focal lesion, hemorrhagic lesion. So this patient had been followed up over a period of 5 years. So if you look at the autofluorescence in the right eye, in the right and the left eyes, 5 years apart, there's not much of a change other than the increase in hypoautofluorescence in the right eye, and the multiple punctate lesions which are seen scattered all around are typically known as reticular pseudodrusens. Now, this is the scan which was taken in 2016, which shows only small drusenoid deposits, and shift over to 5 years, you see extensive large fibrovascular PED with serous macular detachment, with intraretinal fluid, hyperreflective dots, suggestive of type 3 macular neovascularization, or as it is known as RAP. This is another patient which has a type 2 or a subretinal or the classic macular neovascularization, in which you can see the 9 layers of the neurosensory retina being lifted up by a serous macular detachment and the choroidal neovascular membrane sitting there. This is a disciform scar, which is the end stage of any form of ARMD, and it is usually associated by what is known as ORT, or the outer retinal tubulations. These are said to be an abortive effect of the residual photoreceptors, which tend to coil up upon itself, leading to a structure which is hyperreflective in the periphery, and the central core is hyperreflective. In cases of PCV, if we look at it, PCV, usually ICG happens to be the investigation of choice, but there are certain markers and certain structures which can be seen on an OCT and can give you a clue as to what we are dealing with. Now, what has been labeled as the peaked PED by the sheer appearance of it, you can think about PCV. The other lesion being the thumb-shaped PED. Then there is something called as the notched PED, which is nothing more than a PED with an adjacent area of the polyp at the slope of the PED. And if you look at the red arrow, you can see the lumen of the polyp within that area. Then comes the DLS, or the double layer sign, which is also labeled as SIRE by Bailey Freund in 2016. This is also known as the shallow irregular RPE elevation. So these findings put together may hint towards occurrence of a PCV. Thank you.
Thank you, Dr. Jyoti. Anyone has any points, anything to ask, any question to ask? So we put this IC just to see. Nowadays, OCT is the still a very important investigation, and the basic investigation which every hospital, every institute, even basic clinics have. So understanding of OCT is important. So in this, we have to differentiate whether it is intraretinal or it is retinochoroidal difference pathology. Retinal means it's mainly edema part, retinal edema, which can be because of diabetic or other parts. But retinochoroidal means it is basically involving choroidal area, also with retina, and mostly seen in wet AMD cases. So how to differentiate it? This talk is very important in this. This PED, which is a significance of wet AMD, has to be associated with intraretinal changes like intraretinal fluid and subretinal fluid. So this is point to be, just want to highlight this. The second talk is basically on by Dr. Shailesh Kumar. He'll be presenting on poor prognostic markers, OCT based biomarkers in DME and AMD.
Good morning all. Thank you Anubhav sir for the invite. I'll be presenting on OCT biomarkers in DME poor prognostic OCT biomarkers in DME and AMD. Diabetic macular edema, as we all know, is one of the most common cases that we come across in our retina clinics. About 30% of individuals with over 20 years of diabetes can develop diabetic macular edema. It requires multiple intraretinal injections, which is invasive, and so there is a heavy burden on the patient as well as the physician. There are no reliable methods to determine which individuals with DME would gain or lose vision over time. So, what are biomarkers? Biomarker refers to a broad subcategory of medical science that objectively indicates the state of health and well-being of an individual. So these can be anatomical, biochemical, molecular parameters, or imaging features. It'll be useful in diagnosis, disease progression, or predicting and monitoring effects of therapeutic interventions. So OCT, as we all know, with the advancements in the technology, it's like an optical biopsy. It's a very useful biomarker which can predict visual outcome in these cases. Diabetic macular edema can be either tractional or non-tractional. For tractional, surgery might be the treatment of choice. For non-tractional edema, like spongiform, cystoid macular edema, or neurosensory detachment, these require medical treatment with lasers and injections. So, but classifying into these subtypes alone cannot actually prognosticate the diabetic macular edema. So we have these OCT biomarkers in DME. Many biomarkers are described, most common of which are central subfield thickness, drill, which is disorganization of retinal inner layers, hyperreflective foci, integrity of the ELM and ellipsoid zone, cholesterol crystals and hyperreflective crystalline deposits, intracystic hyperreflective material, bridging retinal processes, and biomarkers in choroid like hyperreflective foci in choroid and choroidal thickness. Central macular thickness is the most commonly used biomarker to diagnose, to take a treatment decision, and to see the follow-up. But CMT alone cannot be used as a reliable biomarker to predict visual outcome. So, which are the biomarkers which contribute to poor visual prognosis or poor prognostic biomarkers? Mainly the most important is drill, that is disorganization of retinal inner layers, then ELM discontinuity, ellipsoid zone discontinuity, cholesterol crystals or hyperreflective crystalline deposits, and hyperreflective foci on choroid. So these are the biomarkers in DME which carries a poor visual prognosis. First of all, about drill. Drill is the inability to differentiate between the GCL-IPL complex, inner nuclear layer, and outer plexiform layer. It's the loss of boundaries between the layers of the retina. See here in this picture, you can see that the inner retinal layers so how to find drill? To find drill, you can come from outside the central macula, find the delineation between the inner retinal layers where the health of the retina is preserved, and follow the intact interfaces towards fovea. Point is there. So here you can see that the delineation between the inner retinal layers are lost perifoveally. So if the segmentation zones are present all the way to fovea, there is no drill. If it breaks down and the borders could not be traced till fovea, then drill is present, this much area. So drill affecting at least 50% or 500 microns of the 1 mm central retinal zone was associated with poor visual outcome. Presence of drill causes mild to moderate visual impairment, not severe visual impairment. Disorganization of or destruction of cells within inner retinal layers, including bipolar, amacrine, or horizontal cells. It possibly indicates a disruption of pathways that transmit visual information from the photoreceptors to the ganglion cells. The vessels of the deep capillary plexus supply these layers, and the loss of these capillaries damages these structures. Therefore, the presence of drill correlates with the capillary flow void regions on octa and macular ischemia on FFA. This is the corresponding octa picture of this OCT with the area of drill corresponding to the foveal avascular zone. Next is integrity of the external limiting membrane. External limiting membrane is the plexus between the Muller cells and the photoreceptors. It forms the third blood retinal barrier. When disrupted, fluid goes into the outer retina and it presents as neurosensory detachment. So ELM status is closely related to visual acuity, as is the ISOS junction status in DME. It's useful in the evaluation of prognosis for the treatment. And then integrity of the ellipsoid zone. ELM is this hyperreflective membrane. This is the RPE, and just above the RPE, this hyperreflective membrane is the ellipsoid zone, and above the ellipsoid zone is the external limiting membrane. So in chronic cases of DME, this external limiting membrane loss occurs first, and the disruption in external limiting membrane can lead to fluid seeping beneath the subretinal space. So here you can see external limiting membrane is lost. In this case, there is a patchy loss subfoveally. Here in this case, you can see there is an extensive loss at the fovea. Both ELM and ellipsoid zone are lost. So these carry a poor visual prognosis. Percentage of disruption is a significant predictor of visual acuity in patients with DME. And then there are bridging retinal processes, which are vertically oriented hyperreflective lines between the cystic cavities. They represent residual neural elements that connect the outer and inner retina, thereby facilitating the transmission of visual impulses. Absence of these bridging retinal processes have poor prognosis post-treatment. Here you can see there is a large foveal cystoid. There are some bridging retinal processes here. If these bridging retinal processes are absent, that means if there is a large foveal cystoid, large giant cystoid, that indicates a poor treatment response, and it carry a poor visual prognosis. Even if you inject in these cases, these can eventually result in foveal atrophy, and there may not be any improvement in vision. Then another one is cholesterol crystals or hyperreflective crystalline deposits. On OCT, hyperreflective crystalline deposits or cholesterol crystals appear as single or multiple linear hyperreflective lines of high intensity on or above the RPE without posterior shadowing. On ophthalmoscopy and color fundus photography, HCDs are identified as brilliantly yellow-white or golden yellow lesions. So these are distinct from the commonly observed hard exudates, which appear as yellow flecks in the retinal arcades of DR patients. Plaques of hard exudates are typically seen in circinate pattern peripheral to the area of leakage. These are horizontal and planar. They can be single or multi-layered. They represent intraretinal or subretinal cholesterol crystal deposits. It can indicate chronic vascular leakage, hypercholesterolemia requiring lipid-lowering medication. Involvement of the fovea can cause severe visual impairment. So can I carry on? OCT biomarkers in
Next stop,
AMD.
pass, please.
In AMD, we know that there is RPE detachment, there can be subretinal fluid and intraretinal fluid. Out of this, the most important poor prognostic marker is intraretinal fluid. It carries a poor visual prognosis, poor response to treatment, and poor visual acuity at initial presentation. And also photoreceptor layer integrity, as we have already mentioned in DME, the photoreceptor degeneration and loss are well-known features in AMD and are considered key factors of visual decrease in this disease. There is one outer retinal tubulations which Sir has shown. They characteristically develop in advanced stages of AMD and are associated with the presence of macular neovascularization and geographic atrophy. You can see these outer retinal tubulations as these cylindrical structures with hyperreflective borders. So they can be considered as a rearrangement of photoreceptors as a consequence of injury, and their presence has been associated with worse visual prognosis. Then there is subretinal hyperreflective material, which is also an indicator of poor prognosis. It is common and often persists after anti-VEGF treatment. It may not resolve even after anti-VEGF treatment. It could be made up of fluid, fibrin, blood, scar, and neovascularization, even though it could change over time. So the take-home message is OCT is a good imaging biomarker. CMT was regularly believed was used in all studies, but it has only modest correlation with visual acuity. Drill, photoreceptor layer integrity, hyperreflective foci, and intraretinal fluid are robust predictors of visual acuity. OCT biomarkers help in diagnosis, grade the severity of the disease, and modify our treatment regimen and predict prognosis in DME and AMD. Thank you, sir.
Thank you, Dr. Salish. These biomarkers are important basically to understand, because if they are present, it's difficult to treat the patient, not in terms of treatment response, but in terms of visual acuity improvement. Even if there is a presence of thickening, macular thickening or edema, patient might respond in terms of macular edema resolution, but vision might not improve a lot. So we have to understand these biomarkers. If they are present, we should not run behind drying the macula in all edema cases. Or if the wet AMD is there, we have to understand that vision improvement might not be there in long run. Thank you. Next, I'll be presenting on this OCT in vitro macular interface disorders. Yeah. So good morning, everyone. So it's very important to understand vitreomacular interface also, along with the retinal and choroidal thing, integrity. So OCT is nowadays the most common non-invasive imaging modality for repeatability. It's a two-dimensional imaging, and with this we can visualize each and every part of the retina and choroid and vitreous phase also. So PVD, posterior vitreous detachment, is an inevitable aging process, and when it happens, it usually separates from the all around the retina, and especially in the process of detachment, it separates from the macula and lastly from the optic disc. So usually it's a normal process. You can see on the right side, it detaches normally. But then this is a OCT showing how clearly the posterior vitreous phase is seen separated from the macula. So in such cases, usually macular integrity and alignment will be maintained. In disorders come when there is an abnormal adhesion between vitreous and the retinal inner layers. So there are various types of vitreomacular interface disorders defined by International Vitreomacular Attraction Society: vitreomacular adhesion, vitreomacular attraction, epiretinal membrane, and full thickness macular hole. So first is vitreomacular adhesion. Usually it is seen as a fine vitreous adhesion over the macula without distorting the macula, and vision usually will be normal. So this is just a finding. It is not a it's more of a physiological finding rather than a pathological finding. It can be a small adhesion, a small attachment, or a broad based. This is a focal adhesion or a large area of adhesion. Just an observation more than a pathology. Second is a vitreomacular traction. So this is basically a pathology in which you can see focal elevation in the fovea, and patient usually are symptomatic, comes with the metamorphopsia and difficulty in reading mainly. So this is a OCT showing focal vitreomacular traction with the cystoid changes in the inner layers. Usually vision is good, not normal, but good in such cases, but it can be very poor in significant traction and significant elevation of fovea, which you can see in both the OCT images. It can be focal, or this is a broad based adhesion. In usually broad based vitreomacular traction, usually the vision don't worsens very badly. This traction can be in addition to disc and macula also. So we call it papillomacular traction, in which because of distortion of disc and macula both, patient will have significant vision disability and needs surgical intervention later on. It can be associated with various other retinal pathologies like diabetic retinopathy and wet AMD also, which we all very well know. Epiretinal membrane is basically a remnant of posterior vitreous even after complete PVD, and can cause ERM formation, which is seen as clinically as puckering. OCT shows a hyperreflective line over the retina with the puckering of inner layers. This is a classification showing, this is a grading showing how different stages of OCT are seen. In stage 1, usually the foveal contour is maintained, vision will be normal or nearly normal. Patient will not have any signs. It will be just seen as an additional finding in the observation. Stage 2, patient might have mild visual disability, and in this a foveal distortion will be there with inner layer hyperreflectivity. Stage 3, inner layer integrity will be little bit disturbed, but vision will be reasonably okay. These 3 stages usually don't need surgical intervention. Patient will have reasonably good vision. But stage 4, the whole layer's integrity will be lost, retina will be thickened, and vision will be very poor. So these 4 stages usually need surgical intervention for a surgery. This is a pre-op and post-op OCT. You can see the first image has significant thickening in stage 4. Post-operatively, it has improved to 6.9 because outer photoreceptor layer were intact. But if they are not intact, patient will not have very good significant improvement in vision, even though surgical success is there. You can see photoreceptor loss here. Third, this is a OCT, full thickness macular hole. It is full thickness through and through defect between the continuity of retinal layers, cause significant visual defect. First clinical classification was given by Guess, which is still followed clinically, and it is correlating with the OCT nowadays. But the newer OCT based classification is more precise. That's why we are using it nowadays. Macular hole is divided into small, medium, and large according to the size. So, small is less than 250 micron, medium is 250 to 400, and large is more than 400 microns. This is a OCT showing posterior vitreous attachment at the macula, full thickness macular hole, and it's a PVD at the macula showing operculum. So this is a OCT showing sequences how macular hole is usually formed in the pathology with macular adhesion, then macular traction, and later on which forms a hole. The other clinical mimickers which can mimic like a full thickness macular hole are lamella macular hole and pseudo hole. Sometimes if you don't have a facility of OCT, you can diagnose it as a full thickness macular hole seeing the clinical picture only. So here comes the important role of OCT. Lamella macular hole is basically you can see it just outer layers are intact with a good integrity of photoreceptors, but only inner layers are deficient with minimal thickening. In these patients, usually vision will be good with not much of symptoms. Very minimal metamorphopsia can be there. So these patients needs observation mostly. Pseudo hole in which there is no loss of retinal layers, but retina becomes heaped up, swelled with a inner layer with the epiretinal membrane present over it, and there is a photoreceptor layer loss in outer layers may be lost, may not be lost, but vision will be very bad in this, and usually these patient needs surgical intervention. So these two, lamella macular hole and pseudo hole, has to be differentiated. Sometimes patient can be advised surgery in lamella macular hole, they might not improve at all in vision or as far as vision outcome are concerned post operatively. So this is a very good example shown. This is just with this OCT I want to show you that there are two pathologies which we are seeing in our OPD now sometimes, like premacular hemorrhage. Premacular hemorrhage can be subhyaloid or sub-ILM. This is subhyaloid hemorrhage in which vitreous will be very highly elevated with a blood cavity behind, with a hyperreflectivity of blood behind it. There will be a huge space, but the foveal contour will be maintained, and this patient can be treated with ND-YAC posterior hyaloidotomy. But sub-ILM hemorrhage will be a very small confined area of clinically looking hemorrhage over the fovea mostly. It will not be like a huge area as subhyaloid hemorrhage, and usually they don't need any intervention, they resolve automatically. Very rarely they might need surgical intervention, but mostly they resolve by observation only. This is just to show that on the right side, this is an image of macular telangiectasia in which it's showing ILM draping sign on the right side. On the left side, it is basically vitreomacular traction and ERM formation. So with this normal vitreomacular interface disorder, retina will be thickened, seen on left side, and mactal retina will be thinned out. So should not confuse ILM drape sign with the vitreomacular interface disorder as seen as mactal. We have to be very cautious seeing the OCT of a mactal, which is in which retinal thinning will be seen. Rest all of the pathology, retinal thickening will be there. So take home message is OCT can elucidate anatomic changes at the vitreomacular interface. Appropriate diagnosis of these disorders can help in better management and understanding for our treatment. Photoreceptor loss can affect final visual outcomes. Thank you.
Thank you, Dr. Anubhav, for that informative talk. Any question from the audience? Okay. We'll have discussion at the end. Next talk will be by myself on the importance of OCT in cataract surgery. Good morning, everyone. I'm Dr. Dilesh P. Chandrasekharan. I'll be talking about the importance of OCT in cataract surgery. So, in the pre-OCT era, the armamentarium of the cataract surgeon to diagnose retinal diseases, macular diseases, consisted of fundus examination through slit lamp biomicroscopy and indirect ophthalmoscopy, and fundus photography, and investigations like ultrasonography and fluorescein angiography. So these were relatively lacking, as you can see. So, certain lacunae was that this ophthalmoscopy is severely limited by media haze, and in elderly patients with tessellated fundi, there is total lack of contrast, and we are unable to pick up subtle macular pathology. So, this leads to erroneous treatment decisions. We may advise a premium IOL to a patient who has a macular pathology, and this can cause problems in the end. Patients can end up unsatisfied, and this will lead to litigations. And now even doctors get beaten for these kind of things. So these are mistakes which can be avoided with OCT. So B scan will be giving us information about position of the retina, but not about the function. Fundus fluorescein angiography is an invasive investigation, but it also can miss subtle changes like interface disorders, like Dr. Anubhav pointed out. OCT is a non-invasive investigation. It gives you very precise anatomical information about macular anatomy, and it can also give you clues to the function of the macula. So for premium IOL surgeries, it is very necessary to confirm the macular integrity to avoid unpleasant postoperative surprises. So what to look out for? The things that are easily missed are your interface disorders. VMT, epiretinal membrane and all are very difficult to diagnose through a hazy media, especially in a tessellated fundus. And dry AMD, wet AMD even can be picked up with hemorrhages, but dry AMD is very difficult to pick through a hazy media, especially in a tessellated background. Diabetic macular edema, old vascular occlusions where there are no fresh signs, just sclerosed vessels can be missed. Macular telangiectasia is the most common, one of the most commonly missed diagnoses, and pachychoroid pigment epitheliopathy is earlier we used to call it an old CSR. So these are the things that can be easily missed. So important thing is to trace the structures on the OCT of the patient. So mostly the outer layers have to be traced from one end of the OCT to the other, especially the external limiting membrane and the ellipsoid zone. So these layers, especially at the fovea and throughout the macula, have to be traced. Inner retinal layers may be less important; they also have to be traced from one end to the other. Several studies have evaluated the routine use of OCT for preoperative screening in cataract surgery, which excluded clinically abnormalized, they excluded. So there is a systematic review of 9 studies evaluating OCT as a preoperative screening tool. So the range of OCT detected macular pathology in this was ranged from 4.6% to as high as 26.4%. The mean was 13.7%. And the type of pathology detected was interface anomalies in 32% and macular degeneration in 42%. The largest study of this analyzed in this review was from Sudalkar et al. This is from the Vasavada group in Gujarat. So they studied 1,400 eyes. It's a huge number, and their macular pathology detection rate was 9%, which is quite high. So in clinically, these were eyes which were determined to be clinically normal by the physician, and after OCT they found subtle macular pathology. So I'll come to some cases. This was a 65-year-old man referred for cataract surgery, BCV of 624 and 18. Clinically, through the hazy media, this was a tessellated fundus. We couldn't see much, but on OCT we could pick up vitreomacular traction with almost an impending macular hole. He improved up to 6.9 and 6 with cataract surgery and vitrectomy. So this is a dense nuclear sclerosis with counting finger vision, counting finger 3 meters. We could see nothing through the clinically, but on the OCT we could see diabetic macular edema with a taut posterior hyaloid. So this patient was initially managed with injection and cataract surgery, along with cataract surgery, and she improved considerably even with that. She did not require a vitrectomy. And this is an old lady with the BCV of 618 N10, and she has a vitreomacular traction, but as Dr. Anubhav pointed out, this is just a focal VMT. Outer layers appear intact, so she may not need vitrectomy. She did well just with just IOL alone. So outer layers have to be clearly looked at. So coming to some post-operative surprises, this lady after a after phaco, she had a vision of 6, 9, and 10, and clinically we could see a little bit of parafoveal graying, and this is classical macular telangiectasia. And another patient, after one eye surgery, we were very happy, 6, 6, and 6. Other eye, when we looked at, we went ahead and did surgery, and on the tessellated fundus, we could not see much, but she had an epiretinal membrane. So these are certain scenarios that can be avoided by preoperative OCT. There's another case where there are drusen, and there is, as you can see, some ellipsoid layer loss at the center of the fovea. So this is a poor prognostic factor. So, SWEPSOS OCT biometers these days have fixation scan. They detect the fovea through a SWEPSOS OCT. So they can sometimes pick up subtle macular pathologies, and the technician there sometimes refer the patient back to us, saying that there is something they can see. She needs an OCT. So this happens quite often these days, and when we go ahead and do the OCT, we pick up some vitreomacular traction. This was such a patient, and he underwent vitrectomy along with IOL, and he did well. So, but these are there is a study which studied the role of SSOCT biometers in detecting foveal pathology, and they said that abnormal SSOCT is a strong indicator of an abnormal macula with a high positive predictive value of 86%, but a normal macula on SSOCT biometer scan has a very low sensitivity and negative predictive value, so it cannot be used as a screening tool because it does not detect all macular pathology. So indirect ophthalmoscopy can pick up much more than your slit lamp biomicroscopy, especially in a hazy media. So it may not be OCT may not be considered routinely considering the cost, but visual loss disproportionate to the grade of cataract. Surely you have to do an OCT, and as a routine for all premium IOLs, also maybe you should consider an OCT. And for highly tessellated fundi where you cannot really make out foveal pathology, there also you should consider OCT. So in the pre-OCT era, macular surprises could be excused because there was no way to find them out. But now they are largely preventable because OCT is almost freely available these days, and especially in premium IOLs, it's very difficult to counsel the patient for a post-operative macular surprise. So it is less defensible medico-legally also. So these are certain things I wanted to highlight. Thank you.
Very nicely explained, Dr. Dilesh. Thank you for the very nice talk. So this nowadays, most of us are documenting doing pre-op OCT, especially for premium IOLs, because post-op surprises are really difficult to counsel later on. And patients who are having a cataract vision loss out of proportion to cataract, it's better to do a OCT to see whether there is any problem sitting in the macula or not, because this can create problem later on after cataract surgery. Thank you. So next talk will be on anything you want to add? Okay. So next talk will be by Dr. Kiran Chandran. He is a consultant in Girdhara Institute. His talk is on OCT based differentiation of CSR and its atypical variants.
Good morning. I thank KSOS and Anubhav for giving me the opportunity to present today. My topic is OCT-based differentiation of CSCR and its atypical variants. So CSCR is characterized by the presence of serous macular detachments, and in clinical practice, CSCR has got a wide range of clinical presentation. So multimodal imaging utilizing a wide variety of imaging modalities helps differentiate acute from chronic CSCR as well as CSCR from CSCR-like variants. The commonly used multimodal imaging techniques in routine clinical practice is spectral domain optical coherence tomography, fundus autofluorescence, fundus fluorescent angiography, and indocyanine green angiography. They play important role in both diagnosis as well as classification and prognosticating the disease. Out of these, OCT is probably the single most important tool to diagnose as well as follow up cases of CSCR. So the various features seen in SD-OCT depends on the stage of the disease, and they include serous retinal macular detachment, especially in the acute phases. Then hyperreflective foci within the serous macular detachment. These are indicators of chronicity and indicates the longer duration of fluid in these patients. Outer retinal abnormalities again are signs of chronicity and include ellipsoid zone, ELM deficits, as well as staining and irregularity of the retinal pigment epithelium. Retinal pigment epithelial detachment, the most common type of PED seen are the serous PED, and they are known to be present in around 50 to 100% of eyes of CSCR, especially in the acute stages. And sometimes a small discontinuity in the RP over the PED could be seen, and this is described as the RP rip. So over here we can see the fundus photo of a patient in acute CSCR. The orange arrowheads depict an area of serous macular detachment. And on fundus angiography, fluorescent angiography, you can see an ink spot pattern of leak just superior to the fovea. Fundus autofluorescence also shows areas of hyper autofluorescence surrounded by hypo autofluorescence corresponding to the leak. And on spectral domain OCT, you can see a uniform hyporeflective space in the neurosensory retina between the RP as well as the photoreceptor layer, so indicating of subretinal fluid in the macula. And the choroid is also an important area to analyze in these patients because all these patients are pachychoroid. This is a patient of chronic CSCR in which an area of serous macular detachment can be seen, a large area. And within it, you can see numerous discrete yellowish-white lesions clustered around within it. And fundus autofluorescence shows an area of mottled hyperautofluorescence. And fundus fluorescent angiography shows an area of in-dot pattern of leak. And the interesting finding in OCT in these chronic CSCR patients is that there's elongation of the photoreceptor inner segment, outer segment layers indicated by this green arrowhead. And the yellow arrowheads depict an area of hypertrophic dots seen within the photoreceptor plates. And these basically indicate the deficient RP phagocytosis function in CSCR patients. This is a chronic recurrent CSCR in which you can see an RP gravitational tract beautifully seen on fundus autofluorescence, in which there's a mottled mixed pattern of autofluorescence. And again, fundus fluorescent angiography shows a mottled pattern of hyperfluorescence because of window defects or RP defects. Indocyanine green angiography shows direct choroidal vessels along the tract as well as an area of hyperfluorescence in the macula. And on OCT in these patients, there will be more RP thinning, irregularity of the retinal pigment epithelium, small elevation of the RP above the Brooks membrane, hyperreflected dots in the choroid, as well as collapse of the inner into the outer retinal layers. So this is a patient in which the right eye shows a yellowish white lesion just superior to fovea subretinally. And on OCT, you can see an RP rip that is disconnecting in the retinal pigment epithelium. And just above it, you can see subretinal hyperreflective material. And between this subretinal hyperreflectivity and the RP rip, you can see a vacuole. It's called a vacuole sign in CSCR. So choroid, as I told you, is important to analyze, especially the enhanced depth imaging. So based on various studies, 395 micron is used as a value to diagnose pachychoroid. So subretinal hyperreflective material in CSCR was first reported by GAS, and this condition is more prevalent in pregnant women and those with steroid intake. Although CSCR classically presents a clear SRF on OCT, subretinal deposits may be seen that appear hyperreflective in OCT, described as SHREM or subretinal hyperreflective material. So the OCT features in fibrant CSCR clearly shows a dipping or sagging sign, that is a tent-like depression in the neurosensory retina between the retinal pigment epithelium and the fibrant material, and they basically act like a cushioning effect, like adhesive between this PED and the neurosensory retinum. So the presence of vacuole sign, as I told you, indicates sites of constant fluid egress, and on FFA they correspond to areas of RP leak. So this is another example of a patient with fibrant CSCR in which subretinal hyperreflective material can be seen over here. This patient does not have a vacuole sign, but subretinal fluid can be seen, RP discontinuity, and hyperreflective dots overlying the photoreceptor layers. So other simulating conditions to CSCR, the most important thing is to rule out leakage because the treatment varies in both. Subretinal fluid is present in both conditions. In leakage, you see folds of RP, fluctuation in the ILM and subretinal septa. As you can see in this diagram, RP undulations are seen, multiple pockets of subretinal fluid, ILM folds of fluctuations are seen. Subretinal septa actually separates multiple pockets of subretinal fluid. And another interesting finding is called the Ballard or basilar layer detachment, in which a myoid zone is split and it gives an appearance of interretinal fluid accumulation. And the differentiating feature of subretinal fluid over here compared to CSCR fluid is that it's more homogeneous in CSCR, which appears hyperreflective, whereas this appears like mild hyperreflectivity can be seen within the hyperreflective area because of fibrin and other material deposition within it. So this is another case which we saw in an OPD in which RP mottling can be seen in both the right and left eye diffusely, and fundus autofluorescence picks up this mottled area of mixed autofluorescence. And on OCT you can see multiple the intraretinal cavitations more look like skytic cavitations in both the layers, both the eyes, and shallow subretinal fluid can be seen, RP elevation and hyperreflective and significant thinning of the RP can be seen. There is a patient with uveal effusion syndrome in which peripheral examination is very important because this is a diagnosis of exclusion, and the treatment also varies. OCD shows multiple large areas of subretinal fluid accumulation as well as RP irregularities or elevations. B scan is diagnostic as well, which shows choroidal effusions, choroidal detachments in B scan. This is a patient in which exudated retinal detachment in a patient with CSCR in which subretinal fluid can be seen, and inferior retinal detachment is also seen on OCD sections. And on fundus fluorescent angiography, a leak can be seen in the upper nasal quadrant. This patient is actually lasered and improved vision-wise as well. So the other important masquerade is polypoidal choroidal vasculopathy because both fall in pachychoroid spectrum. ICG and OCT should be done in tandem to differentiate these two entities because ICG identifies PCV as areas of polypoidal lesions and branch vascular complexes. So this is a patient of acute CSCR in which an area of, you can see area of serous macular detachment and yellowish orange lesion can be seen at the fovea, and drusenoid deposits can be seen scattered around the macula. Fundus fluorescent angiography shows a leak, in-glot pattern of leak in the late phases, and on ICG you can see hyperfluorescence in the mid phase phase of polyps. And OCD sections taken through the polyp shows notched PED, and sections through the leak shows subretinal fluid and serous PED. So this patient had coexistent PCV as well as CSCR. This is a patient of chronic CSCR in which you can see RP gravitational tract, and on ICG, when we did ICG through the polyp, we can see a thumb-shaped polypoidal lesion, thumb-shaped PED as well as subretinal fluid. A double layer sign can be seen, separation of RP from the underlying Brooks membrane, and minor patchy areas of intraretinal fluid. So this patient again had coexistent PCV with CSCR. Type 1 macular neovascularization is CSCR because it can mimic KSCR, type 1 macular neovascularization. So in these patients, double layer sign is present, as I already explained. It's a separation of RP from the Brooks membrane. So I can see just you cannot see much fluid on clinically. You can see RP defects as well as prominent orange discoloration of the fundus. Very faint suspicious leads can be seen on fundus fluorescent angiography, and dilated choroidal vessels can be seen on ICGA. When we did an OCT, we saw a subretinal fluid at the macula and a subtle double layer sign, that is RP is getting separated from underlying Brooks membrane. And on OCTA, we found a network in a C-fan pattern at the RP Brooks complex area, suggesting of type 1 neovascularization. So the last masquerade is best vitiliform macular dystrophy. So it presents as a bilateral yolk-shaped lesion affecting the macula. The classic pseudohypopia may not be visible in all cases, and ancillary testing may be needed. So this patient had a vital eruptive stage of Best disease, and a subretinal yellowish white lesion can be seen in the macula with discrete yellowish lesions scattered around the boundaries. Fundus autofluorescence shows those hyperautofluorescent dot-like lesions, hyperautofluorescent dot-like lesions along the boundaries of lesions with mixed autofluorescence centrally. And on OCT, you can see discontinuity in the photoreceptor layers between it. The ELM is continuous, and you can see the yellow arrows, the blue arrows depicts the external limiting membrane. The red arrow over here suggests areas of narrowed outer nuclear layer, and the photoreceptor layers have lost continuity. They appear disruptive. And this mount that you see over here is corresponding to the yellowish white lesion seen subretinally. So these are few of the masquerades and distinguishing features of CSCR on OCT. Thank you.
Thank you, Dr. Kiran. Very nicely explained our typical variants.
Thank you, sir.
So CSR is a very common pathology we are seeing in our OPDs, but yeah, we have to always think if we are not seeing a usual picture of CSR, like patient, if it is more than 50 years of age with CSR presentation, we call it adult onset CSR, or CSR with atypical presentation or differently looking picture, we have to always think of other situation associated with it. If we are having any doubt, it's always better to do additional imaging like fluorescent fundus fluorescent angiogram, or in cases above than 50, additional imaging of ICG. It's better to do these things to rule out whether it is just a CSR or any other pathology. Because VKH, which is a very common pathology which can mimic like CSR, it's an inflammatory pathology in which steroids are indicated, but CSR, steroids are contraindicated. So if we give, thinking of CSR, if we give conventional treatment in VKH, it will worsen. Thinking of inflammatory pathology like in CSR, if we give steroids like VKH, CSR will worsen. So we have to differentiate all the pathologies. If in any doubt or any suspicion, better to do additional imaging of angiogram to rule out the CSR clinically. Any other additional points, sir?
One another differential that you can add in CSR is dome-shaped maculopathy. In that you can identify from the OCT that there will be a convexity at the macula, convexity of the choroid at the macula.
Yeah, dome-shaped maculopathy is seen in high myopics in which there is a posterior staphylomas. So at the posterior bulge of, at the edge of the bulge, usually you see elevated retina with a subretinal CSR-like fluid. So usually don't respond. This patient just need observation. They need not to be treated with laser or injection, whatever. Very nicely pointed, Dr. Shailesh. Thank you. Anyone has any questions, please? Thank you, Dr. Kiran. So, see, if patient don't have epiretinal membrane, if patient vitreomacular attraction, if patient don't have schitic space or large cavity, all these OCT chronic poor prognosis biomarkers, these patients might not improve a lot whatever you do additionally during the cataract surgery. But if patient has minimally intraretinal fluid cavities or subretinal fluid, which is an early sign of diabetic macular edema, commonly seen, addition of intravitreal anti-VEGF injection at the time of cataract surgery will definitely improve. And steroids basically are you can give steroids, but IVTA basically there are studies which have shown that 4 milligram IVTA has a lot of post-operative complications, but instead of it you can give 1 milligram IVTA, which can have very minimal complications. And with cataract surgery, doctors are preferring anti-VEGF, but IVTA can be given in such cases, which will definitely improve in patients who are having these good prognostic factors. In poor prognostic factors, even IVTA might not work very well.
On OCT, if there are a lot of hyperfetti foci, these hyperfetti foci indicate inflammation. So these cases you can consider steroid injections. They'll be useful more than anti-VEGF.
Rather than giving IVTA, I think Ozurdex or the dexamethasone implant is relatively safer as far as the outcomes are concerned, because IVTA, the amount of crystals which go in, is not is variable depending upon the amount you have drawn, and God forbid something happens, it is very difficult to manage such conditions. So IVTA versus dexamethasone, I would tip off more favorably in the side of dexamethasone implant rather than going for an IVTA. Initially, we used to use IVTA, but then we burnt our hands more times than not.
That's the reason most of the time we are not giving IVTA with cataract surgery now. We are seeing with anti-VEGF. If they are not responding, post-operatively we are prescribing Ozurdex rather than IVTA a lot. It is more, IVTA is more or less stopped in most of the centers. Thank you. Thank you, everyone. All speakers, please collect for a group photo.